Declan. Good to be back. I'm good. What have you been up to today?
A lot of surgery this week.
Yeah.
6 or 7 prostatectomies. What about you?
A lot of surgery. Still getting that PhD over the line.
Yeah. Okay. You had a nice paper published today.
Thank you. It was very nice to get our perspectives paper in Nature Reviews Urology.
Yeah. Well, should we put a link in the show notes?
Yes.
So if you are interested in our favourite topic of lutetium PSMA, prostate cancer theranostics, Renu has first authored a beautiful review about the immunology of prostate cancer with respect to radioligand therapy, and it looks fantastic.
Yeah,
so congrats.
Nice team effort. It's lovely to see these things in print. It just looks so beautiful.
Yeah, after a lot of
a lot of effort, many months.
And the PhD is nearly there then.
Nearly there.
But we're not talking about prostate cancer today, are we?
No, we are still buzzing from the excitement of Keynote 564.
Yes.
So we're going to continue in a similar theme of kidney cancer.
We are, and we have 2 fantastic guests here in the studio with us. It's a great pleasure to welcome our colleague, Dr. Lewis Al from Peter Mac. Lewis, how are you?
I'm good. I'm so happy to finally be in the studio. I've been watching the podcast and work with you guys at Peter Mac, so thank you for inviting me.
It's great to have him.
Actually, Lewis is one of my biggest mentors with my PhD. I mean, he's been amazing,
Renu.
and he's so experienced because not so long ago he finished his own PhD.
Yeah, so I joined Peter Mac just under 2 years ago now, but beforehand I did my PhD over at the Royal Marsden Hospital and the Francis Crick Institute, and that's really where my interest in kidney cancer started. And of course, over all these years, I've been following a lot with Rana McKay's work. I'm sitting right next to her at the moment, so very happy to be here and chatting to you guys today.
Oh, fantastic. He's let the cat out of the bag. And we have a very special guest with us today.
And Rana McKay from UC San Diego. Welcome.
Thank you so much. It's so exciting to actually be here live in the studio with you all. We've done various podcasts in the middle of the night in San Diego and here.
That's right. Rana, I still remember one podcast where you logged on. I think it was in the middle of COVID, and I still remember your little girl in a Halloween.
Yes. Yes, that happens frequently. They're running around in the background,
And she's accompanied you to Melbourne this time.
Yes. It's exciting.
Yeah. It was so wonderful to have you, and we must mention that Rana is a newly minted professor.
So it's
Professor McKay.
Yes, so very exciting.
Congratulations. It's
exciting times.
Lots of high achievers here today.
What a great accomplishment.
Yeah.
Yeah, so Rena's here, and Lewis is here, so we're going to talk about kidney cancer today.
It's a great focus of interest for both of them, and we have a lot to learn.
And Rena's here for a few days with family, a little bit as well, but you're also working a bit.
Yes.
There's a big immuno-oncology conference that happens in Sydney every year, supported by MSD. And there's a big GU component of it this year. So, Rena, you're one of the international faculty, and we're looking forward to going to Sydney tomorrow, actually.
Yes. It's going to be a great meeting and a lot of highlights from kidney cancer. I think there's been a lot of amazing new therapies, new diagnostics, biomarkers. I mean, it just piles on each and every meeting. So it's been super exciting to see the just revelations.
Yeah. And I think, when you get so much new data and great outcomes for patients, it's important to put it all into perspective, isn't it? Because I think we can kind of get lost a little bit in the hype.
Yeah.
And I think that's what we want to do today.
Yeah, that's what we're going to do. So we asked Lewis and Rena, could we talk about 3 sort of interesting areas in advanced or sort of high-risk renal cancer? So that's what we're going to go through today. We're going to talk about Adjuvant.
We have to talk about
adjuvant therapy for renal cancer post-nephrectomy. So all you urologists out there, there's a lot changing, and the way in which we approach patients after nephrectomy is definitely changing. So we're going to give you a sort of a masterclass on adjuvant. Then we're going to talk about what has been a very fast-moving area, metastatic renal cell carcinoma. First-line options, because that's changed a lot, but it seems to me to be confusing. I get confused in the MDT every week, Lewis. What are the options? What should we be picking? So we're going to have a quick masterclass from these 2 on how we
My
can...
favorite topic.
Your favorite topic, how you choose, and how do we advise patients what to choose. And third, then, a little bit of future gazing and what else is going on. What gets you guys and girls excited about stuff going on in renal cancer.
That sounds
three great things to talk about today. Before we go to dinner, because we're going to make Rena work tonight for dinner as well.
I love it.
Because you are here with MSD, so thanks to Baz and team at MSD in Australia who are supporters of the podcast, and they've kindly allowed us to drag you into the studio for a chat today as well with GUcast.
Excellent.
All right, off you go, Renu.
Topic 1, adjuvant. That's an exciting time right now for adjuvant
Super exciting time,
right?
yeah.
Very exciting, but still a little bit confusing as well, actually.
Yes.
I mean, it's great that we've got lots of data, but, there's a lot to tease out, and I guess the current standing is that we do have the exciting OS data from Keynote 565 of adjuvant pembrolizumab, but, in the background of all of this are the other adjuvant studies as well, which haven't shown the same outcomes with Prosper, Emotion 010, and Keynote and Checkmate 914.
Yeah.
So there's a lot to unpack there actually, because each of these trials have a little bit of difference between each of them, and would love to hear first from Renu. What is your view?
Yeah.
From where Pembro lies with adjuvant treatment? Are you using it? How are you picking patients?
I think patient selection and risk stratification is the first question to tackle, because I think why we use adjuvant therapy is because people's risk of having recurrent disease is high, and what can you do to mitigate that risk? To essentially, the goal is to not just delay recurrences, but actually prevent recurrences, potentially cure more people from actually ever developing metastatic disease. So I think the question is in how do you identify those high-risk patients? The people that were enrolled on 564 included people that had T2 grade 4 disease all the way to M1 NED, which is a crazy wide spectrum with a lot of heterogeneity regarding their risk of recurrence. And our current models for predicting risk of recurrence are really crude and largely depend on clinical parameters, pathologic parameters, stage. And I don't think we actually do a really good job of actually appropriately risk stratifying. Now, that being said, the bulk of the patients that were enrolled on 564 were actually the T3 patients. They were the lower grade T3 patients. That was the bulk of the patients that were enrolled on the trial, not the M1 NEDs, not the T4s, not the N1s. That's not the most common type of
Which is an
RCC.
important distinction to make, because I think a lot of people feel that maybe this OS benefit is driven by those patients. But it's important to recognize that, in fact, a vast majority of these patients were on that lower end of the spectrum.
Correct. Yeah, correct. Absolutely. And I think, this is land-breaking data. Like, this is impressive. Like, to have an OS benefit in the adjuvant setting with a checkpoint inhibitor, I think this is actually a huge deal. When we look at the degree of benefit of adjuvant therapies in other malignancies, like in breast cancer and lung cancer, like the degree of benefit is on par with what we do with other disease settings for adjuvant therapy. So I think that the data speak for themselves. I think the point about the other trials, we can totally nitpick apart the other trials. So, Emotion 010 was atezolizumab, but atezolizumab isn't even approved as a therapy in advanced disease in combination or as a monotherapy. 914 was combo dual IO for 6 months. It did not include M1 NED patients, included T1 patients. Yeah. And I think the threshold to tolerate IRAEs in the adjuvant setting is really, really low to stop therapy. There's only 6 months of treatment. And Prosper, I wouldn't even put Prosper in the same category because, kudos to the cooperative groups for conducting this amazing trial. Like, it was a magnanimous effort. And it actually required a lot of collaboration with our urology colleagues, because it really was a shift in practice. We were having to biopsy patients. Some people, they needed to have a diagnosis of RCC to get on the trial. And that wasn't really part of the practice of biopsying renal masses. And it also included non-clear cell patients. So I think there was a lot of issues with that trial. So I don't think the negative trials take away from the positivity of 564.
That's a good sign. Yeah. That's what we want to use.
Basically.
Yeah, I agree. I think, with all the data from, Keynote 564 and all the different trials at the moment, I think there is a way to make use of all the data that's available as well, though, to make, finer, more nuanced decisions about patients. And actually, I wanted to raise one of the meta-analysis done by, I think Brian Renu was involved, where they analysed all the adjuvant studies and then tried to pick apart, trying to see whether there's anything else that we can use to better pick patients. And I think sarcomatoid changes in patients, even in the adjuvant setting, probably benefit most. And I think that also makes sense mechanistically as well. So I think that's one particular group that I think we need to keep an eye on, and we need to be friends with our pathologists to pick up that change, right?
That's a good point.
Absolutely. Certainly, Declan, when we see these path reports, there are certain key words that make you worried. And we've always said this, we've always wished we had an option for these patients in the post-operative setting. But I guess Lewis, my question to you then in Australia or in Melbourne, is there a way we can further risk stratify, or should we be considering everyone who fits Keynote 564 criteria for adjuvant treatment?
I think in Australia it is a little bit more tricky because there's not currently a PBS-funded option. I think there's a few different layers of discussions we need to have with patients. One is, of course, their risk for relapse, and we can use those clinical parameters to guide that discussion. Second, of course, is cost. As well, but we've got to balance that with the potential benefit, and third is the potential exposure to IO toxicity, which we know it is low in the setting of anti-PD-1 monotherapy as well. So I think we have to have all of these multi-layered discussions for sort of a joint decision-making process, and I think it's definitely necessary to have these conversations for patients with high-risk resected renal cell carcinoma, for whether they should undergo adjuvant pembrolizumab. Like Ren said, we're talking about a potential chance of prolonging disease-free survival and potential chance of increasing cure. So these are important high-stake discussions.
I think, Renu, we can presume, though, the second factor about reimbursement will probably go away, because with an overall survival benefit, countries like Australia, many countries will support the reimbursement. There will be a discussion. So what we anticipate for urologists listening to these podcasts out there is that there will be a time in very many countries all around the world over the next 6 months or 12 months that urologists will need to identify which patients. You do a lot of kidney cancer surgery, Renu, to send on to you, and it'll be really the first and the third thing you'll be talking about is selecting, okay, within the whole study population, which are the ones, like there was only 8 or 10% T2s, for example. So what about all those intermediate risks, and then balancing the toxicity? So I suppose that's it, Raina. What are your urologists like in the US now? Are people becoming aware of it? Because I think what we think is that for most urologists listening to this podcast, they're probably not aware of this. They're seeing a patient today in the clinic, 6 weeks post nephrectomy with a PT3A grade 3 cancer who might fit the criteria, but we have to educate ourselves about this because we never refer these patients to medical oncology.
No. And I do think that the education is increasing. I mean, in my practice, I'm certainly seeing increased referrals for discussion around adjuvant, and it's definitely a lot of shared decision making because people's risk benefit scale is very different. Somebody may have the same exact clinical features and may elect to do adjuvant, and same exact clinical features and may choose against it. Yeah. So I think we're definitely seeing those referrals. And I think too, from the surgeon, I don't want to speak for our surgical colleagues, but it's nice to say, hey, we've resected your tumor, you're high risk, but we have something to offer that could potentially mitigate that risk. And I think there's something to be said about that. And I think actually even beginning the discussion early on, a lot of times we know, somebody's got a large renal mass, IVC thrombus, going in when you resect them that they're going to be high risk.
Absolutely. Yeah.
So I think being able to have that discussion, I think it's going to be interesting to see what happens with biomarkers. At ASCO this year, we saw some really exciting data from Emotion 010 on the KIM1, which is kidney injury, molecule 1, which is a soluble, real-time, nice, easy biomarker to check. And now we've got 3 studies where data about KIM1 was not only prognostic, but potentially predictive. So, it's been looked at in ASSURE, it's been looked at in 914, and then the large data set that Laurence Albages presented at ASCO, demonstrating that it could potentially be predictive to IO. Though I think we were chatting about this, Lewis, mechanistically, why would it be a predictive marker to IO therapy? But, it's a simple, easy, cheap blood test.
And I think we're not talking about KIM1 enough, and how exciting that actually is in the context of kidney cancer. For many years now, we've been looking for that biomarker of our response in terms of tissue-based biomarkers, and it's been incredibly difficult. One of the major challenges is that kidney cancer is subject to intratumor heterogeneity. So it really depends on which part of the tumor you sample, and therefore a tissue-based biomarker just hasn't yielded. ctDNA hasn't been fruitful either because kidney cancer just sheds so little cfDNA to begin with. So, the fact that we've got potentially a easy to measure biomarker in KIM1 is actually very exciting. Still a bit of work to do, I think.
Blood test, it could be amazing.
It could be amazing. I think we still have some work to do to understand where it's coming from, which part of the tumor, which patients are shedding, how it's involved, but very exciting, actually. Yeah.
Lewis, one other question before we could talk about this for ages, I suppose. Is there, with adjuvant treatment, you're potentially treating a lot of patients that don't have any viable tumour at all. Is there a move to move this into the neoadjuvant space and maybe giving neoadjuvant pembro when there is some viable? Because renal cell cancer is an immune-rich environment. We've got the NAPSTA trial that Shankar Shiva's running at Peter Mac, and that's an exciting space, isn't it?
It really is, actually. I think we can take learnings from other tumour types, particularly with successes in melanoma and MMR deficient colorectal cancer, where application of immunotherapy with the tumour in situ yields excellent responses because you've got that opportunity for immune priming with the tumour, still in place. So I think there definitely needs to be data and trials in the neoadjuvant setting for kidney cancer, and I think it's incredibly exciting, actually. I think it potentially could be a game-changing space. Yeah.
So much changing.
Renu. I know we could talk about this one all day.
But definitely the conversation for urologists in high-risk kidney cancer has changed.
So what's your wrap-up then for part one, especially for urologists listening out there?
Yeah, I think, when you're counselling patients before surgery and then when you get the pathology and you're counselling them about their risk of recurrence, I think it's important to let patients know that there is an option. Yeah. And then you really have to tailor it to that particular patient situation. I think much more collaboration between urologists and medical oncologists in running that discussion and helping the patient come to a final decision.
MDTs are valuable.
Yeah, absolutely.
And we have had some very detailed podcasts about this recently. We'll put links in the show notes. We had the OS discussion with Alex Kudakov and Matt Siebelman from Fox Chase. And prior to that, we had Tony Shueri on as well with Alex. So very exciting stuff. So let's keep on a mission to educate ourselves on that. All right, next.
Metastatic RCC.
Yes.
Yeah. So this is where we need a lot of education.
It used to be easy.
It used to be very straightforward.
And we had MDT at Peter Mac this morning, and Renu was in as a guest as well, and there was a bunch of metastatic kidney cancers there, and listening to you all with Lavinia and Ben and everyone battling back and forth about options. It is, it's great, isn't it? Bewildering. But how do you select combination IOs, VEGF, blah, 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 cabozantinib? Shoot.
I think for me...
Make it simple first. Make it simple.
Dumb it down.
When I first approach somebody, I'm like, one, do they even need treatment? That's the first decision to be made for metastatic disease, because there are certainly a subset of patients who have favorable risk disease, have low volume oligomets to their lungs. Like, do they need treatment at all? Do they need systemic therapy at all? Or can they be treated with metastasis-directed therapy? But then if you get to the point of deciding, okay, burden of disease is high, somebody needs systemic therapy, I think the two decisions to be made are, okay, do they need IO-IO? Do they need IO-VEGF? And I think there's probably a very small subset of patients who you're probably going to give single-agent VEGF-TKI to. Mm-hmm. And when I look at the data, I think for me, with IO-TKI, you've got tremendous short-term gains. You've got really high objective response rates. The clinical benefit rate is 90% plus. Primary PD rate really low, amazing PFS. I think there continues to be OS benefit over time, but the question is about long-term durability and sustainability of a potential durable remission. With IO-IO, I think long-term gains. If I've got somebody before me who needs an immediate fix, I need something right away, I'm probably not leaning down that option. Primary PD rate, 20% with IO-IO. So 1 in 5 patients are going to just not respond at all.
Right.
1 in 5 patients are going to have an amazing response. And there's no biomarker to tell me who's going to be in the 1 in 5 that's going to do amazing, who's going to be in the 1 in 5 that's going to do not so great.
Yeah.
And then the PFS is also not as great as you would see for the IO-TKI. But then now we have 8-year follow-up data from 214 that was presented at GU ASCO by Nazir, and the data look really excellent for long-term durability. And so being able to track these patients over time, and we'll talk about the favorable risk. I know we were kind of chatting about, well, what do you do now with favorable risk with the long-term data over 8 years, demonstrating that maybe there could be a subset of patients who are favorable who could benefit from IO-IO.
There you go.
Initial impressions.
Yes.
There you go. Good opening pitch.
Yeah, no, I mean, that's such an excellent summary of, the complexities in the field at the moment, but, all the different options that we've got available for patients. And I think, when I chat with medical oncologists of the tumor types, they would say, you haven't got that many drugs to play with for treatment of metastatic kidney cancer, but actually the treatment algorithm is very complex. Like you said, we've got to look at the clinical phenotype. We've got to decide when, nephrectomy is indicated. We've got to see which patients we can observe. SABR comes into the question, and then we've got the different sequencing and combinations of treatment, right? So I think you can be very nuanced in all of this. And I think, underlying the treatment landscape for metastatic disease is this IMDC criteria, which is, a list of clinical and blood-based parameters that we categorize patients into: favorable, intermediate, and poor. And we're sort of stuck with that a little bit in selecting patients for systemic treatment, but it was really never designed to select patients for immunotherapy-based treatment. So that sort of hampers the field a little bit, I have to say. I think we do have to look for other biomarkers to select patients. And Renu, you talked about this group of favorable risk patients, which traditionally we know they don't progress as quickly. Yeah. These are the patients we can watch. But then it's complicated, right? So what do we do with this favorable risk? When do we do the doublet treatment? Yeah. When do we observe? What's your sort of treatment algorithm in working up these patients?
I have to say, with the 214 data demonstrating long-term benefit for the favorable risk patients, hazard ratio for OS in the favorable risk around 0.82, 0.83, which is profound. That's impressive. It continues to get better over time. The thing about the favorable risk patients is these patients are asymptomatic. Yeah. They tend to be doing well. They have low disease burden. Their likelihood of seeing a second-line treatment is very high. And so, if there was a really nice survey that was done by Casey Cure and Dina Battle about what are the things that matter for patients around treatment decisions. And honestly, what matters for patients is efficacy and cure and long-term durability. And so, we have that discussion. I would not necessarily hold back on IO for somebody with favorable risk, because I know they're going to potentially do well. And if they fail their IO, they can easily be salvaged with VEGF TKI. And then I think the other thing about the VEGF TKI combos is that, people are going to be symptomatic when they go on IO TKI. The rates of treatment-related AEs is high. And with IO, once you get them through the hump of IPI, they can sometimes do quite well on maintenance nivolumab. So I think from a quality of life standpoint, that also impacts decision-making. So I think it's very complicated. Yeah.
But it's such an important point, though, really focusing on what actually patients want and the toxicity, expected toxicity for the long term, actually. When a WhatsApp group around the country of GU medical oncologists, and this topic came up, and one of the medical oncologists said, if I had favorable risk disease, I would choose Ipi-Nivo first rather than just single agent TKI because of quality of life benefits. Yeah. And I think that's something that's not talked about enough when we just go over the clinical trials data. And I think it is an important discussion. Yeah. Yeah.
Absolutely.
Can I just ask, so, as we enter into this era of adjuvant pembro, if patients progress once they've been exposed to pembro, how does that change their options in the long run? Yeah. If and when they develop metastatic disease?
So definitely very evolving field. Yeah. I mean, we saw data from CONTACT-3 basically demonstrating no benefit to continuation of IO. This trial did have its limitations. It was atezolizumab plus Cabo versus Cabo mono for the post-IO progressing setting. We saw a press release about T-Nivo2, also negative trial of continuation of nivolumab in people that progressed on prior IO with layering in tivozanib. Each of these trials have their limitations, but I think in every context we've looked at this layering strategy or layering in IO if somebody has stable disease or primary PD. We just haven't seen the same robustness as in the front line. So, I do think that your best shot at goal with IO is your first shot at goal with IO, but we still don't know what to do in the post-adjuvant progression.
I think we don't know, and I think, the trouble with having definitive, guidelines, such as if you've been exposed to IO first, one time you can never access IO again, is just not nuanced enough for, good clinical practice, I think. I think you really need to see whether a patient progresses, is it during IO, and what time interval that might be after progression. I think we can learn from other tumor types as well. If you've had a long disease-free interval after adjuvant immunotherapy, I think they should be given another go at immunotherapy, actually. Actually, I think Tom Pauls had just published a review on Lancet Oncology just this month. I think he was actually quite prescriptive, and to say, if a patient has had adjuvant immunotherapy, adjuvant pembro, if it's after more than a year of disease-free interval, then perhaps rechallenging is actually very reasonable. And I tend to agree with that. In the lack of data, I think that's a reasonable way to practice.
In a combination.
Well, that I think is a bit more difficult. I think, if we were using it in frontline metastatic disease, definitely combination. I think that is standard. Yeah.
I think the other thing to think about with combination, especially if you're going to layer in Cabo, you're going to end up dose reducing the Cabo, because the Cabo dose with Nivo Cabo is at 40. So it's is the patient better off starting at full dose Cabo with robust TKI, or being at a lower dose with a drug that they're progressing on? So then it's like, are you actually hurting patients by, giving them a suboptimal VEGF TKI? We don't know we don't know,
Well, we don't have much experience yet in Australia with Cabo Nivo, where we're using pembrolizumab at the moment, and or Eapen as the other doublet. So I think learning about the different regimens is really important as well. So.
The other thing, Lewis and Raina, is the concept of these subtypes of renal cancer, and what options are there for the rarer subtypes. Clear cell clearly has won out in this, but Declan, we just recently had a translocation RCC, and IO drugs don't seem to work as well. What are the options? Are they really limited, or are there options out there?
Yeah. Well, actually, I would love to hear from Rena. I know you've invested a lot of sort of research efforts in non-clear cell. I feel like two things are happening, actually. One, we're understanding more and more about this non-clear cell histology subtype. We're understanding there's many multiple different molecular subtypes, which complicates things even more. But on the same time, we've got not that many treatment options. So there's quite a disconnect, I feel like. What's your take on the current landscape? Are patients actually benefiting from our newer understanding, or not quite yet?
I think, first off, as a field, hopefully we'll move away from just subtyping all the variant histologies into the umbrella of non-clear cell, because they all have pretty heterogeneous responses to IO, as we've come to see from a lot of the... it's basically a series of single-arm phase 2s of combination therapies that have demonstrated a signal of activity. And I think the responses are certainly lower than what we see in clear cell RCC. The primary PD rate is higher, but I think when you look at it just numerically compared to single-agent TKIs, the numbers do look a little bit better, with the exception of probably chromophobe. So I think as a field, I would hope that we would actually be able to do isolated studies in papillary, isolated studies in chromophobe, isolated studies in translocation, and actually be able to really dissect out what's the right treatment based off of biology. But I think in general, I do favor an IO-TKI strategy for those individuals. And I think the IO data of Nivo-Ipi has been really actually pretty poor for the non-clear cell patients. Response rates on the order of 20%, primary PD rates much higher. So I think, it's a little bit tougher regimen, I think, to select.
I think, there's another comment to be made about, this newer molecular understanding of non-clear cell kidney cancer and how that should impact drug development, right? Yeah. I think we're in a space where we probably need to, tailor drugs specific to a particular subtype and the molecular features of that. And I think that's where we're going to see successes. And we probably have to accept that we're not going to get hundreds and hundreds of patients. Yeah. And I think if we see a signal that's rational and it's a targeted treatment, and I think that's what we've got to pursue.
Yeah.
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 Very good. Part 3.
Time for our gazing into the future segment.
We want to ask you to just say what gets you excited about what's currently going on in renal cancer, or maybe what's coming. But before we do, we wanted to pick your brains, Rena, about belzutifan.
Yes. Yeah.
So we get a lot of queries from our VHL patients in Australia about belzutifan, and there was a lot of excitement when positive data read out showing that there's a disease stabilization effect for these patients, and at least one of our patients has gone to the US post-surgery here just to get access to belzutifan. And Lewis, you can comment on availability here, and it falls under kind of rare cancers strategies. But what's your take on this? I mean,
it's an excellent drug. It's a HIF2 alpha inhibitor that very potently blocks HIF2 alpha, which we know is a driver mutation in 90% of clear cell RCCs and 100% of VHL disease. The clinical benefit rate for VHL disease patients is nearly 100% with long-term durability. These are very homogeneous tumors, at least the VHL tumors are, where they're driven by that one alteration. And so people can be on therapy for a long, long time. I think where belzutifan was developed in RCC initially, it was later line. Data from the LIGHTSPARK 005 trial demonstrated improvements in PFS and response over kind of everolimus, which is a pretty low bar in RCC, I would say. I think the objective response rate was on the order of 22%. PFS was around 5.6, but there was a durability kind of to that PFS. So I think from a side effect standpoint, the major tox is anemia, hypoxia, and I have to say patients really welcome a TKI sparing strategy after they've been on sequential TKIs and not having to deal with the diarrhea, hand-foot syndrome, hypertension. I think the anemia is pretty well managed with dose reductions. We actually do use EPO. I certainly use it in my clinic, and usually just a couple of doses in people who actually need it. So I think it's been a nice drug, but I do want to see it move earlier in the landscape when people aren't multiply refractory to VEGF targeted therapy, where they've probably developed lots of resistance mutations around like their driver VHL mutation. Like I think that probably earlier on it's going to be more efficacious, which we've sort of seen data with Cabo-Bel, and hopefully 011 will read out soon of lenvatinib, belzutifan, kind of more earlier on.
I'm really excited about belzutifan actually, and I think we're probably on the brink of an avalanche of data with all the sweep of LIGHTSPARK studies having belzutifan in the various treatment settings, right? So I think it's going to make a definite impact in the way that we treat patients across different settings, even in adjuvant and possibly even neoadjuvant setting, and earlier in the metastatic setting as well. And, in Australia, we haven't got direct access or funded access to belzutifan at the moment, but, if it's available, it's something that I'll definitely be, trying to use and incorporate in the treatment algorithm for patients, actually.
Yeah. Wonderful. Yeah.
Cool.
Very cool.
So what else? Wrapping up, we got a couple of more minutes. What's getting us excited? Go, Renu.
There's when you have one effective drug, you're going to have other drugs. So there's actually other HIF2 alpha inhibitors that are actually being tested. Arcus, NICANG, they've got agents that are in clinical trials right now. Other things, we've got Zanza, which is basically a MET inhibitor, a VEGF MET inhibitor that's being tested in the Stellar studies. We've got Stellar 001, which is looking at it in combination with atezolizumab, Stellar 002, which is looking at it in combination with Nivo/Ipi, Stellar 009, which I think is looking at Zanza in combination with HIF2 alpha inhibition and also IO therapy. So I think there's other TKIs that are also being looked at. It's really exciting to see the work on radioligand therapy in RCC.
Yeah.
Saw some of that this morning at multidisciplinary tumor board, looking at CA9 and CA9 targeting radioligand therapy. So I think that has potential. The ADCs have been a little bit of a bust in kidney cancer. Very low response rates. As we think mechanistically, even though the target may be ripe, is a targeted chemotherapy strategy an appropriate strategy in RCC? We don't even use chemotherapy to treat this disease. And all in all, the data has been really suboptimal. Low response rates, high tox, peripheral neuropathy, thrombocytopenia. So I think we need to rethink the strategy around ADCs.
And Lewis, I mean, I must say, it's really impressive, the CA9-based PET imaging and then the theranostics associated with it. I think after, the PSMA PET imaging for prostate cancer, this has been really kind of wow from our nuclear medicine colleagues.
Yeah, I mean, just knowing the successes that lutetium PSMA has had, we're really trying to learn from that experience. And, carbonic anhydrase is upregulating clear cell renal cell carcinoma. And it really is a good target, but I think there's still some lessons to be learned as to how we can, leverage that into therapy rather than just, imaging. But I think it really is promising, actually. We'll have to see.
Lots of great things in that space.
Most interesting, I think, segueing with the adjuvant setting, because I think it really has the opportunity to revolutionize. You've got like a high-risk individual that actually is metastatic, and they should get doublet. And you've got somebody who's got a completely negative CA9 PET, and maybe they actually don't need adjuvant.
Yeah.
And so I think it has the opportunity to completely revolutionize what we do in the localized and post-nephrectomy monitoring setting.
The images we saw this morning of the CA9 was just astounding. I think we were lighting up, hair follicle cells.
That was so bizarre.
Because
you could almost make out the patient's face because of how the uptake in the hair follicles and the beard and in the hair.
Yeah.
It's like, that's a patient's face. You can see it.
The resolution, it's
incredible.
Sublime.
I mean, the concept is being able to treat what you can see.
Yes.
And, in Australia, I think we've always been big believers in imaging biomarkers. And like you say, this could really revolutionize that aspect of it.
And so just to clarify, this is not zircon, it's not the girentuximab imaging. This is a small molecule ligand. Michael Hoffman and team, who were in the meeting this morning, published it in JNM a few months ago, 3 patients with this small molecule ligand from Debio Farm in Israel. But it is sensational. It's still targeting CA9, but using a small molecule instead of an antibody, with all the advantages that come with that. It's almost the exact same story we saw with PSMA.
Yeah, absolutely.
And over the years, it's the small molecules that made it convenient. But this was a patient they scanned last week, so we now have another trial.
And it's lutetium, not
and
zirconium.
Exactly.
So it can be imaged right away. They don't have to come back in 3 to 4 days for their imaging. And
it's great.
I mean,
you heard it first here at GU Cast. It's exciting stuff.
We have to drag Michael and Ben Tran in for a chat about it. But,
absolutely.
That's good. That was
learned a lot.
I did.
All in 40 minutes.
All in 40 minutes. That was a superb run round hot topics in renal cell.
And what an exciting space it is. It's really thrilling to know where things can go and at lightning speed.
I mean, it's amazing. I mean, I think of where we were a decade ago when overall survival was less than a year for somebody with metastatic disease. And now patients with metastatic disease, the average survival is 5 years at least. And there's people that are having long-term disease durability and potential cure, and it's just so exciting.
The patients are the winners here. It's our job, as oncologists and urologists and everybody in the team to learn how to use these tools we've got now, right? So very exciting.
Well, thank you very much to you two for coming into the studio.
Thank you.
Let's go get a drink and dinner.
Yeah.
Cheers.
So, cheers to that. So we've got it's what day of the week is it? It's Thursday evening.
So it's a typical Thursday evening
We've
in
been
Melbourne.
working all day, and we're going to go out for dinner now. And lots of other kidney cancer experts and trainees and nurses are coming to dinner to hear Renu talk tonight. And we've got some great cases to discuss.
Yeah.
It'll be great. I have to say, my wrap up, and they are enthusiastic about this. These two,
they really are.
If you want to hear what passion for your disease area sounds like, it's like Rana McKay and Lewis Au talking about kidney cancer.
There we go.
Great. Well, that's all we have time for on this episode of GUcast. It's been really. We need to do more kidney cancer. I know we say it every time we do it, but it's always popular with the audience. So.
Absolutely.
And we'll be back soon with something else that's not prostate cancer. We've got a testis cancer episode coming next week, which I think
from the great Rob Hamilton.
Exactly. That's all we got time for.
Thank
you.
Thank you so much.
You're welcome.